I just want to take a brief moment to introduce our guest speaker, Dr. Sheetal Silal. She joins us from the University of Cape Town, where she's a professor and the director of the Modeling and Simulation Hub for Africa, or MASHA. MASHA is an interdisciplinary collaboration that aims to use modeling and computer simulation as a tool to guide policy for key public health priorities in Africa. And so her personal research has centered on modeling as a tool to develop strategies for disease elimination, especially malaria. But more recently, she's obviously been dragged into spending quite a bit of time on emerging threats and pandemics. She advises the government of South Africa on control strategies and long-term scenarios for the COVID-19 epidemic. So we're really very fortunate that she's able to take an hour of her time and talk to us. So we're going to hand it over to her and hear about her experiences.
Thanks so much, Wendy, and thank you for having me to present today. I'm just going to share my screen, so it should be a second. There we go. I think that should be visible now to everyone. So good afternoon and morning to the class. Today I'd like to focus on the importance of, it's a topic that I think is quite close to my heart, and that is about incorporating context and diversity in modeling when performing practical modeling on the ground. And so what I'd really like to talk about today is to share some of the reflections on modeling experience that I've had in modeling in LMICs around the world, focusing particularly on malaria and then contextualizing it with COVID-19 as well. I'd like to thank the class also for doing the background reading that I had set, and I think that will lead to some fruitful discussion after the lecture. So my group, MASHA, we have been involved for many years in malaria modeling, and our focus has always been along the lines of supporting national malaria control programs to make better decisions, whether it was for funding applications or towards just designing elimination policy. We've always been at that at the forefront, or at the interface of modeling and policy development. And then more recently now with COVID-19, modeling has again come to the fore, but instead of supporting long-term decisions, has really been supporting immediate decisions. And so the flavor of modeling has actually changed, I believe, from what we would traditionally do as research projects or even working with governments compared to what we had to do in the emergency setting. So when you're developing a disease transmission model, there's a set of standard steps that one takes. You review your existing knowledge base on the biology of the disease, what treatment options may exist, where's global policy at the moment. You collect data relevant to answering your research or your policy question. You develop your model, your mathematical model, using whatever method really is commensurate with the available data. You also then validate your model to be an adequate representation of the situation that you are mimicking or simulating. You conduct sensitivity analyses, run your model scenarios stochastically, and you communicate your model results, their strengths and limitations also to your client. When you're at the interface of policy or decision making and modeling, I feel like there's quite a bit more than that one needs to take into account compared to just the standard steps of building a transmission model. And for me, in my experience, I have learned that in whatever country I am working with or working in, it is vitally important to have an appreciation for the local context, the culture, and the diversity of the setting. So it is not enough to understand, let's use malaria as an example, it's not enough to understand the biology of malaria and the global focus towards elimination. When you're working in particular countries, you need to read carefully on the local country policy. What are the local country goals? What are the monitoring and evaluation reports telling you with respect to how policy is implemented? What does the health system infrastructure look like? What characteristics are there that you should be aware of in terms of surveillance, how data are captured, how data are sourced, as well as a local epidemiology? What makes a disease behave differently in one setting compared to another? And in the case of malaria, we find that between countries, there are some aspects of disease and its management that are completely different. For example, access to treatment. In some countries, access to treatment may be completely passive. What that means is that if one is sick, one has access to get to a healthcare system to receive a diagnosis, a malaria diagnosis, and then proper malaria treatment. But in other systems, access to care is not equally available to everyone. It might be available in urban settings, but not necessarily available in rural settings. What happens then? Are there community malaria workers who get malaria diagnosis and treatment to people where access to care is sufficient? What about, or insufficient? What about the ability to seek care in the first place? Does one seek care via private means or via public means? Is the quality of care received different if one accesses care via a private facility versus a public facility? Similarly, with the use of insecticide-treated nets, it is not enough to consider that so many nets have been purchased and therefore distributed. What about nets that are actually used? How many people are sleeping under nets? What is the attitude towards net usage in some places? So, for example, I've worked in countries where people have been people are amenable and accepting of the use of nets and sleep under nets on a daily basis. In other countries, nets are distributed to the entire country, almost one net per person in terms of distribution, but most of those nets, over half of those nets, are not actually in use. In other countries, there's simply just no appetite for using nets. And so it really requires an appreciation for culture and attitude towards these interventions to be able to model them appropriately, to be able to incorporate their impact into your modeling, so as to make future suggestions as to which interventions would be better employed compared to others. Likewise, we've got to take into account environmental considerations as well as social behavior. And I'll come to one or two of those examples in the next slide. So one of the readings I had suggested was an investment case that we had conducted a few years ago, maybe 3-4 years ago, for malaria elimination in South Africa. And so the reason for this investment case in the first place relates to one of the questions raised by someone in the class, where the question was that South Africa is an upper middle income country. Is it not receiving funds from international bodies like the Global Fund and so on? So South Africa actually receives no funding from international bodies. The malaria efforts are completely or 100% funded by domestic funds or domestic resources only. So the taxpayers' money in South Africa is what is used to fund malaria elimination and anything related to malaria going forward. And so there was a need to establish this investment case, to project the path to and the cost of malaria elimination in South Africa, because if we were going to go for elimination in a couple of years' time, there needed to be a target pot of money dedicated towards malaria elimination. And to date, with, or at least until then in 2018, with competing health risks like HIV and TB, malaria was really not considered a problem in South Africa at all. And so there was this need to allocate these funds for malaria elimination if we were going to go for elimination. And so when this project was initiated, modelers were one of the first resources that were sourced for the project. So being South African myself, I was approached by the National Department of Health to say, we need to make this funding case. We know that modeling is the only resource that we have, or the only scientific resource that we have to be able to estimate this investment gap and the impact of future interventions. So can you develop a model for South Africa and model a set of scenarios, a set of interventions that may achieve elimination, because we don't know what's going to work, And then let's cost it and estimate what funds we have and what funds we're going to need to ask the government for. And that was the purpose of this particular project. So when working in this situation, we formed a team called an investment case task team. And this team comprised of the National Department of Health, the Malaria Control Program, myself as a modeler, but then all the related scientific experts as well. So the entomologists, the clinicians, those working on international cooperation, the health economists. So everyone came together, all those who work in some part of the malaria system, be it in a lab or be it in a government office, coming together to weigh in on the validity of the data involved, on the validity of the scenarios, and the impact that it's going to have on future policy. The duration of the project, I guess, technically was 6 months, though the whole effort lasted to be around a year. And what that involved was having several data meetings. So meetings before we even started the modeling to understand things like, how do we define the population at risk in the various geographic areas? That the population at risk had been changing from year to year. You can imagine that as a country approaches elimination, your cases are so low that in some years you may have no cases in areas, but you may have a minor outbreak in that a few years later. Cases are very sporadic. And a lot of it speaks to where that transmission is coming from. So in an elimination setting like ours in South Africa, having a high prevalence neighbor in Mozambique with significant importation of cases and movement between countries in the SADC region, we have a lot of imported cases of malaria in South Africa. And so understanding that data, understanding the sporadic nature of transmission, we had to do things like define population at risk, look at how data was defined by geographic lines and backdate that data if boundaries and so on had changed. We had to embark on an entire costing data collection program in order to understand how costs were allocated at different geographic levels. So from national all the way down to provincial and to district, which is admin levels 1 and admin levels 2. How much money was spent by the nurses on malaria versus something else, on what portion of the vehicle cost was allocated to the malaria program and compared to other health needs. And so there was a detailed costing exercise that was undergone so as to feed into the model. Now, that's on the costing side. We spoke about data-related meetings, but what was going on the modeling side? As modelers, I often envisage us as spiders, so to speak, where we are gathering little bits of information all around the system so that we can model the system as a whole. And so we had the costing on the one side, we had the underlying data on the other side. But in terms of policy, and not just the policy that we would like to do, the optimal scientific policy, but it's about the policy that is acceptable to the population in whom is going to be implemented or for whom is going to be implemented. Those were the discussions that we were having at a scientific and at a national level. What scenarios should we test? And we evaluated a variety of scenarios, those in use already, such as indoor residual spraying. South Africa is one of few countries in the world who still sprays DDT. Or uses DDT as part of indoor residual spraying. And we have no net usage at all in the country, but we have a wide scale spraying program. And so looking at the different sprays that would be used into the future and the impact and the spraying strategy to be employed into the future. Outside partners such as Gates Foundation and others asked us, why aren't you modeling nets? Everyone else around the world is using nets. Why aren't you going to model your nets and distribute nets to the population? But this is where context and understanding of culture came into decision, that it would be nets are a completely foreign concept to the South African population. And much work has been done to establish acceptance of an indoor residual spraying as an annual task that gets completed every single year, to have to change the way people sleep and the way houses and bedding areas are set up to incorporate nets is an entire shift in thinking. And for a country so close to elimination, that would be disadvantageous at this point. So not from a scientific optimization point of view, but purely from a context and a practical application point of view, we decided not to model nets. Similarly, we also decided not to model mass drug administration programs, because such interventions are themselves not culturally acceptable in South Africa. And so it was these detailed discussions on weighing which interventions we should be modeling, which we shouldn't, and what the impact of those interventions would be. And once we had this level of discussions, we were then able to incorporate it into our models and design a set of scenarios that would be, that may or may not lead to malaria elimination. And one of the scenarios that we implemented, and this really was novel in terms of using domestic resources, and was applauded by many of the global funders as a decision, was to do what we call source reduction, was to use domestic funding to help Mozambique, or neighboring Mozambique, and the provinces closest to South Africa, to reduce the malaria prevalence in those provinces, because that has a knock-on impact in terms of the importation of malaria cases into South Africa. Our models were able to demonstrate that you can do all you like within a country, but if your imported cases are still continuing unabated, despite having border surveillance units and so forth, because of the impact of asymptomatic cases, the knock-on malaria cases transmitted would have sustained malaria, local malaria transmission for years on end. And so the greatest benefit, and the only way really to achieve malaria elimination, was to engage with our neighboring Mozambique and help them reduce their prevalence. And so what the final findings were from our investment case was that the government of South Africa committed 320 million rands, or around $20 million to as a grant to support the malaria elimination effort for the next 2 years. We also funded an additional 30 million rand, or $2 million per annum, to be allocated towards co-financing a mechanism to support malaria reduction activities within Mozambique. And so what this investment case represented was really, it was unprecedented to be able to have this amount of funding and political support for malaria elimination in South Africa, and really raise the bar with respect to a focus on malaria, and advocating for domestic resources to be allocated to what are non-priority health initiatives. And so the one thing I'd like to highlight as part of this investment case is the role of modeling. That modeling here was directly linked to this funding allocation, and which is very powerful for modeling. But it did not just require that we did a modeling exercise, wrote a report, made a publication, and that is what the South African government used to allocate the funding to the program. In fact, it happened a little differently. The project report and the publication happened months after the successful decision for committing funding was made. And that is because the modeling team worked with the government to develop the funding applications, these internal funding applications, to then submit these funding applications way before we even thought about publications and final reports. So often when you're working with policymakers, you don't worry about the academic needs of publication and writing project reports. We tick those boxes afterwards, where the real goal is to help the national governments achieve and meet their deadlines to achieve their goals. So that was, this is one of the one of my favorite, I think, investment cases or applications, because it really is a direct link between modeling and successful outcomes with respect to funding. Another case I'd like to talk about briefly is in Melanesia and Timor-Leste, where we performed in collaboration with the institutes here on the side on behalf of the Global Fund. We were identifying opportunities for investment where the Global Fund had a certain pot of money that was allocated to these countries, Vanuatu, Timor-Leste, Papua New Guinea, and the Solomon Islands. And the question for the modeling team was, how do we spend this money to be the most effective? The reason why I'm bringing up this particular case study, because for me, it was a very good example on how to maximize the findings of modeling. And so what I did, my contribution to the study was up here. It was a scenario-based modeling exercise on the feasibility of elimination and the resource requirements. So projecting the path to elimination and costing that path at a national level for each of the 4 countries, in line with what was suggested in the National Malaria Strategic Plans, and what would be suggested as what would be direct scale up of those interventions. But then we also considered some new interventions as well for the area. So I did a scenario-based modeling at a national level, but the discussion as to how implementable those scenarios really were, that was contextualized by 2 adjacent studies that were ongoing as part of this project. So the WHO and the Nossal Institute for Global Health at University of Melbourne, they conducted a national level health system and financing analysis. So they went in to look at the health system itself and what the health system's strengths were, what the weaknesses were, where areas for opportunity were in terms of strengthening the health system. They also looked at the finance layout of the health system, how finances were allocated to health, how sustainable that was, and how movement of money moved from a national level down to the different provinces. In many of the countries in Melanesia, you can imagine that some of the countries are archipelagos of hundreds of islands, or many islands, and so the ability to implement a consistent health program, not just on your main islands, but on all the islands, and ensure adequate access to healthcare is a particular challenge for the area. The second study that was ongoing at that time was a subnational level operational feasibility assessment conducted by the Malaria Elimination Initiative at UCSF. And what this study was doing was looking at, again, at the very smaller level, so subnational, looking at each of those islands, for example, to see operationally how is the health system functioning at these lower levels. And so now what we were able to do, once we had these scenario-based projections from the model, we were able to contextualize it in terms of how it would be implemented at a practical level using the subnational assessment, but then how it would also fit into the greater health system needs and the health system strengthening that would be required and the financing infrastructure. So these 3 studies came together in order to allow us to highlight which interventions should be funded and what aspects of the health system needed to be strengthened in order to achieve maximum gains from those particular scenarios, those particular interventions. So for me, in highlighting that modeling is a multidisciplinary process, it's not just the domain of mathematicians or clinicians. Here we were working together with with systems and or policy analysts, as well as looking at the implementability of the interventions we are modeling, so that we could really make robust suggestions as to where which interventions and where these opportunities for investment lay in these 4 countries. So lastly, as I round off, I'd like to highlight some of our experiences with respect to COVID-19 in South Africa. And for me, that's really a question of what do we do when data are not available? And COVID-19 has been one of the lessons that we as modelers have had to learn and had to adapt and adjust with respect to making these projections at a time when the need for long-term projections is critical, but there's no data on which to base our models. And we know that is the case in LMIC. We know that surveillance systems have either historically been weak or with limited budgets, these may not always be directed towards health system strengthening. And so for COVID-19, in my experience and modeling, not just in South Africa, but also in neighboring Mozambique and in Namibia as well, we were able to surpass some of these limitations by forming expert panel groups. So where data were not available or data were not available for your local setting, these expert panel groups were able to weigh in on which data were reliable and which data were not. And in many cases provide assumptions that could be used in models or parameter values that would be more reliable or contextually relevant compared to some international parameter values. And so this really was about contextualizing this emerging local data and understanding where the data comes from, what populations is it representing, and if I include this in my model, what are the ramifications for the greater population? So in South Africa, for example, right at the beginning of wave one, there was no local data as to hospital admissions. And so what we were able to assess at the time was that there was information from many European countries on the length of stay in hospital, for example, in critical care. Now, in the Netherlands, I believe the estimate was 23 days. And so the question was, should we apply a length of stay of 23 days for South African cases? And in speaking to a group of intensivists, those who work in intensive care and in critical care in South Africa, we were able to understand that actually we cannot use values such as that because we have such limited critical care capacity to begin with that, and critical care is so expensive in South Africa that in fact, more than 5 to 7 days would be unreasonable. And so we really decreased those values. In other cases, we also were able to understand that the criteria to get into intensive care in a setting like South Africa was completely different and far more strict compared to what may have been the case in settings where there's a lot more critical care capacity available. And so before we even put not pen to paper, but I guess hands to writing code and developing our models, we have to understand the context and we have to understand the context of the health system and the data and what that data represents. And so in South Africa, we also took into account things like excess mortality, knowing that not everyone has equal access to care. So what I learned, at least in my experience in this last year of modeling for COVID, is that when you're engaging with policymakers, the needs for your modeling change very quickly. So in South Africa, we've had 3 waves of COVID so far and are anticipating our 4th. And in each wave, the need for modeling has been different. In wave 1, and this actually relates directly to the report that I had shared with you as prescribed reading, was really based on wave 1, which would have been ending in September, October last year. In this case, we had to generate projections very quickly, and to generate the ones in the report that I'd shared with you, we went through 11 sets of projection updates in order to get to the ones that were in the report shared with you. Those projection updates were reflecting data as it were arising, starting right in the beginning with using international estimates only, and then as local data emerged, incorporating local data and local understanding. These projections were primarily used to plan, should we be having restrictions or not? Should we be moving or relaxing restriction levels? Should we be developing or opening up field hospitals? What quantities of drugs are to be planned for in hospitals versus clinics? Do we have adequate staff in hospitals, or do we need to allocate more staff? Will we have enough ventilation and oxygen in critical care, for example? We also extended beyond the health system itself to look at the, and we are still supporting actually those planning the number of and placement of burial sites and mortuary containers, and supporting the COVID-19 health budgets. But along with making those projections at the very early stages of the epidemic, we had to be equally responsible in communicating the uncertainty of our projections, where data didn't exist. The fact that that new studies are being conducted and emerging in the literature every single week, growing in real time. And to date, actually, we still have a very poor understanding of a population's acceptance of non-pharmaceutical interventions, or what we call public health and social measures now. So we had to be very responsible in how we communicated our model findings, while also being useful enough to present these model findings to the partners in government, so that it could help them in doing the planning and making the decisions that needed to be made at this early stage of the epidemic. When wave 2 came along, and that was in December last year, we could see that cases were increasing, and we were getting asked by government to develop our models and present a second set of projections for wave 2 as to how long the wave would be, and whether it would be worse than wave 1 or wave 2. Would our hospitals be under pressure? So because we are mechanistic modelers, the dynamic models that we build require that we understand why cases are increasing, or why infection is increasing. We went about looking at all the different sources of data, from mobile phone data to understand mobility, to surveys that were being conducted on public health social measures, to understanding the spatial connections between areas. Some areas may have still had high cases compared to others, understanding why cases might be increasing into a second wave, and that is starting to increase around the country. In light of all of this considerable uncertainty, we were unable to find or to pin down which drivers were causing this resurgence. And we made the very unpopular decision at the time to not model. And we made this decision because if we were to choose certain mechanisms as what were increasing infection, and they were not actually increasing infection, then we would be providing a completely incorrect set of projections. And so we decided to change direction, and instead of mechanistic modeling, we went straight into data analysis, where we developed a resurgence monitoring framework. And that's a bit of what you see here. We developed dashboards of various resurgence metrics, looking at things like how many cases are there per 100,000 population? How is that changing over time? What's the percentage increase? Are there upticks in cases? Are there sustained increases in cases? Using a variety of metrics that we have presented in this dashboard, which is live and continuing to be updated if you'd like to have a look at it. And in this dashboard, we presented these metrics at a provincial and a subnational level, district and sub-district level, so that we could assist the government to understand when cases were increasing and how the trends in cases and admissions were changing across the entire country. And then a month or two later, in December of last year, the news emerged that actually it was the beta variant that was causing this increase in cases. And so we felt that our decision to not model was justified, because we would have been completely incorrect, because in October, no one had even really thought of modeling variants at that time. And so when the variants emerged, this news of variants emerged at the end of December, we were now armed with a proper understanding of the mechanism for increases in cases. And so we started collecting more data, so that when wave 3 modeling was required in January of 2021, we were able to adapt our models once again to be useful. And so this is exactly what we did. I revamped the modeling framework to incorporate variants, to incorporate reinfection and cross-infection, as well as to incorporate vaccination. At the time of wave 3, we weren't we didn't have any vaccines, but we were thinking about planning. And so we included vaccination in a very loose manner for wave 3, because we weren't sure what vaccines we were going to be using and what the effectiveness of those vaccines would be against the different variants. What you can see here where my cursor is a plot of the variant takeover, or the proportion of infections from the different variants. The models got quite complex, where we suddenly had to model infection transmitting within and between the wild type. Here in blue, you can see here in October of 2020, 100% of our infections were all the wild type. Slowly in pink, that got taken over by the beta variant. In gray here, you see the data points and the genomic surveillance teams. And then somewhere around April, the Delta variant came along and very quickly, very rapidly, as you can see, outcompeted beta to now remain as 100% or close to 100% of all infections circulating in the country at the moment. And so our models needed to be able to capture these different variants and their different transmission characteristics in order to properly reflect the transmission setting in South Africa. And so once again, this highlights the need for multidisciplinary approach to modeling, because we had to work with the genomic surveillance teams. We had to work with the clinicians and with the intensivists to understand what was happening in the hospital framework. We also had to work with the demographers to understand the impact of excess mortality and deaths occurring outside the hospital framework. As I mentioned, we set up the model for vaccines, and as we are approaching wave 4 now, we've now incorporated a very detailed vaccination component into the COVID models, where we've separated our population by healthcare, those in the healthcare workforce, those with comorbidities, and everyone else, stratified by the different age groups so that we could do vaccination targeting. And now the third wave is over, we've just, as of last week, developed our first set of fourth wave projections, looking at the anticipated vaccine coverage and the impact of what changes in contacts may achieve as we look forward to the December summer holidays in the country, as well as what the impact of a hypothetical variant with immune escape characteristics might do to the high seroprevalence, or to the high level of previous infection, which has already been measured in the country. But to do all of this, local data has been imperative. So we have incorporated a series of seroprevalence studies, local seroprevalence studies in our models, as well as hospital outcomes analyses and vaccine trials, surveys that are available, as well as mobility data from cell phones or mobile providers. Now, what are the lessons? And I think this is quite important, something I'd like to dwell on. I'm talking right now in the context of COVID, but these are really universal lessons that modelers who work in policy or work directly with in the policy development setting should be aware of. The first is that integrity is our only currency. What that means is that as modelers, you need to maintain scientific objectivity and scientific independence, that we are not the decision makers, we are not the policy makers, the ones designing policy. Our job as modelers, our job as scientists is to present the objective scientific evidence to the policymakers so that they may use it along with other considerations to develop policy. Politics, as we know, is fickle. During COVID-19 in South Africa, we've been supporting the national government throughout the epidemic, but throughout the epidemic, we've also been through 3 different health ministers in the country. And so we've had to establish a relationship and show our usefulness to the health system, not just in having a good relationship with one policymaker or another. Why we've been able to stand the test of time really is because we have successfully managed the scientific independence and also demonstrated our usefulness and willingness to support better decision making in government. And that's why I say here, quite colloquially, get into a committed relationship with the health system, because if we want to be useful, we know that decisions at a policy level are going to be made, and they're going to be made with and without any modeling support. So if you want modeling to be part of the evidence base in generating these policy decisions, we need to be agile, and we need to be able to adapt our models and make our modeling output useful so that this continued interaction with our partners can be maintained. You've also got to develop a set of communication skills where it's not just about communicating to government. We've got to be able to communicate with the media. We've got to be able to communicate with the public. In my case, I've had to do a lot of communication with lawyers with respect to court cases and public hearings and so forth. And so we have to be very skilled communicators as modelers, knowing that our field is not necessarily an easy field to understand, that sometimes when we show our projections, it does look like an estimate of exactly what's going to happen in the future, but our modeling is also fraught with many different kinds of uncertainty that require responsible communication. I've highlighted a few times in the presentation that modeling is a multidisciplinary field, and that I found that to be true in every single project that I have embarked on in the last decade, and it's not to be undermined. That our modeling is only made better if we work with others in related disciplines to properly understand the data and the context. I've also learned in the course of the COVID epidemic, that the use of interactive dashboards and communication tools, especially clear plots and focused output, focused differently for each partner who requires the information. These are all very useful ways to enhance and advance the implementation of your model findings and accelerate the understanding of model findings. So I'm going to leave it at that, and I do hope that you've perhaps today seen, maybe understood the differences between COVID and malaria. Both are emergencies, I guess, but one was a greater emergency, or took greater priority in the last few years compared to the sustained efforts of malaria. But really, what I would like, the main message that I'd like to bring across today is that every modeling project you do is different. And it requires empathy on the part of the modeler, and it requires an appreciation for the context and the local nuances and characteristics in making these applications. So thank you, everybody, and thanks again for the opportunity to present. And I'd be very happy to take any questions.
Thank you so much, Dr. Salal. That really resonated with me, what you said, that integrity is our only currency, and I think understanding how to present uncertainty in these models very clearly. And I just have so much respect for you that you said, this is beyond uncertainty. Like, we can't model this because we're going to give you answers that we know will be wrong. So I think those takeaway messages really resonated with me. And it occurs to me that that looking at how models guide actual spending is sort of the gold standard for understanding whether your model has impact in public health programming and policy. So I wanted to open it up for questions, especially from our students. We had one question from Arthur already in the chat, and he asked, must there be a new model with each new wave of disease? I don't know if you want to say anything about that.
So I don't think necessarily a whole new model. I think it depends. What has each wave of the disease, each new wave brought that was different from the previous ones? So when we are just modeling the wild type, there wasn't a need for a multi-strain model. But as soon as variants emerged and were circulating, we had to adapt or almost duplicate the previous model to take into account the competition between variants. So my policy, you could say, with developing models is that a model needs to be purpose driven. If you're and it needs to be appropriate to the situation. From wave 3 to wave 4, for example, we haven't developed an entirely new model at all. We've simply expanded on the vaccination module in the model to be more specific to what was actually required. And okay, I guess we did expand to include yet another variant, because we had 3 wild type and 2 variants, and then to incorporate a 4th variant, it did require some expansion. But again, it just needs to be purpose driven.
Mhm. I wonder, so a couple of our students had questions about the new malaria vaccine. I don't know if Veronica, if you're able to turn on your camera and maybe address the question that you had about the new malaria vaccine.
Yes, so first of all, thank you so much for your presentation. Really appreciated hearing everything you have to say. But yeah, so with that, my question was just, how do you think the new malaria vaccine approval will affect like your costs and incidence projections for malaria, and what components of the vaccine and its distribution can inform future models for and policies for the new malaria vaccine?
Sure, thanks. So the new malaria vaccine has been recommended to be most useful in middle and high prevalence countries. And the malaria vaccine is aimed at children, and some of the recorded effectiveness values has been a 30% reduction in severity of cases in children. And we know that in many malaria severe cases in malaria lead to death. It's a very high severity case fatality rate there, right? So so I think that two things that in Africa, for example, the vaccine is aimed at falciparum malaria. So in Africa, high prevalence countries and the medium prevalence countries would find the vaccine most useful. How we would incorporate it into models. This is something I've just given, I think, 5 minutes of thought to, because it's a project I have to start in the new year, which is how will that impact the South Africa-Mozambique relation? So of course, we wouldn't consider the vaccine in South Africa having a very low prevalence approaching elimination, but our neighboring country, Mozambique, would very well consider using the vaccination. So mechanistically, you would need to, we know that the vaccine doesn't protect against infection. So those vaccinated and those not vaccinated would be subject to the same force of infection. They have the same chance at transmission compared to everyone else, assuming there's no change in behavior, so to speak. But this would be mosquito-related behavior, being malaria, right? But then when you're, upon becoming infected, and you would have you would have in your model a parameter governing the likelihood of a clinical malaria case progressing to severe malaria prior to treatment. Now that is the rate that would be reduced by the vaccine effectiveness for those who were vaccinated compared to those who weren't. And so that's where you'd have to separate your vaccinated population from your unvaccinated population. So mechanistically, those are the general ways in which you would incorporate it into your model. Now now that's not enough. That's just mechanistically how we do it. You've got to think of a couple of things. Let's say there's a high prevalence African country and they would like to implement the vaccine. We've got to take into account how would they pay for the vaccine. So what coverage would be possible, not even just coverage, how many vaccines would you be able to procure, and when would they be able to be procured? So would it be a delivery of like a once-off delivery, which you could then implement throughout the year? Would it be a case where, like in COVID, tranches of vaccines were delivered? So it really depended on supply, on when you could actually administer those vaccines. We then need to think about the coverage. Now, where would those vaccines be equally accessible to an entire country? Would it first be rolled out in the metros, and then once the mechanisms are established, training has been done by the staff in order to be able to implement the vaccines? How would we take that into account? So I feel like we've got to understand the implementation of the vaccines first, because that will then tell us what coverage can we include in our model, who and where, who's getting vaccinated and where are they living to get vaccinated, and when would they get vaccinated depending on the supply. So this is what I mean about that whole systemic nature of thinking about the practical things first before we even get to implementing anything in code.
I wanted to invite Kate to ask a question that I think is really interesting regarding the intersection of malaria control and COVID-19.
Yeah.
Okay, let me see. Can you hear me?
Yes, you can. Thanks, Kate.
Yeah, I was just wondering, so I know that in the article that you had us read about malaria, we know that a lot of the malaria cases in South Africa are like imported from other places. And so I was wondering if any of the like lockdowns or decrease in traveling due to COVID had any sort of like, basically like any sort of tangible effect on malaria cases in South Africa over the past year.
Sure. So it did. Now, the way our lockdowns worked in South Africa was that right in the beginning of March last year, we had a 5-week hard lockdown where the country, borders, everything was just shut down. So that was a really strict lockdown. And so you could see in the reported malaria, and this was malaria diagnosis generally, because people were scared of accessing the healthcare system, right? Not just from the imported case transmission side, but also from local transmission side. You can see a drop in cases. But as the country opened up and borders have been opened up, but given that most of the travel is actually economic travel occurring on a day-to-day, weekly basis between Mozambique and South Africa, the cases have in fact increased again. And the border clinics that were the border surveillance clinics have been picking up these malaria cases. I think our health system is yet to recover post-COVID, that other activities such as active surveillance, where you'd go to people's houses and you treat and you test them rather than waiting for them to come to the clinic. These had to all be aborted during COVID. And so I think the system still has to reach a normal point, which maybe we might see next year, but it has COVID has had an impact in reducing the number of reported cases, while not necessarily changing the, it may have temporarily been a temporary reduction in the transmissibility of COVID, because there's fewer imported cases. But as we've seen with mass drug administration, if you've seen models of mass drug administration where something is implemented once off but then not sustained, you see an interruption in transmission that after a year or two reverts back to the old equilibrium. As the world gets back to normal, and we do expect to see the same thing with respect to COVID. COVID just sort of being a little transmission interrupter in the middle, but not sustained.
Great, thank you so much.
So Kimani from Moy University put a question in the chat that I wanted to share with the group. And he's wondering whether how modeling can be used to advise on when to implement booster doses for COVID-19 vaccine.
Sure. So that's something we're actually considering at the moment. So I'm looking at the chat. So your first part of your question on what sort of data do we need to collect for vaccine escape variants, the way we are doing it's informed by a second analysis that's being conducted in the country, which is what we're calling the reinfections analysis, knowing that asymptomatic cases will not be detected. Right. And so what we are doing is using identity numbers or social security numbers in order to link duplicate or people who have had multiple cases. So this is biased by symptomatic infection, but we do have widespread testing in the country. And what we're using here to measure these numbers of reinfections is then to back adjust for asymptomatic cases and to look at the force of infection that would have generated these reinfections the way we're seeing them. So taking into account then, that upon becoming infected, there's a low chance that you could have a symptomatic infection and then a lower, with an ascertainment rate chance of you being diagnosed and then twice. So taking into account the systemic factors, we work back to understand, has the force of infection changed over time? And that's giving us a good idea of also vaccine waning over time, knowing that it may be different in our population compared to where efficacy or effectiveness trials were conducted. And then what we do is we incorporate this in this level of waning and reinfection into breakthrough cases. We would fit to the breakthrough cases, the estimated breakthrough cases in our models, and look at the waning rates, and then incorporate the impact of a booster to see whether it would actually be protective enough in the face of seroprevalence as well, that your vaccine effectiveness may be waning. But in a country like South Africa, where we have at the moment estimating 60 to 70% seroprevalence, prior infection is offering a lot of protection, that even if your vaccine wanes, you do have immunity from, a strong immunity from prior infection as well. So it does require a very good understanding of the situation in which you're working. So yeah, that would be one way that I would approach it.
So Haotian, you had a couple of very detailed questions about some of the assumptions in the model. Did you want to bring up one of those questions for Dr. Silla?
Sure. I have several questions, like as Andy said, that's somehow detailed. And actually, my first question is about the introduction part of the paper. Like it is mentioned that South Africa is defined as a upper middle income country, and I was wondering like why is like you or the other authors emphasize that they have there is a lack of like global refunding for this country.
Yeah, so that's something I mentioned earlier, that our malaria elimination efforts, that we don't receive any global funding, and so it's entirely domestically resourced. And so if one has to go for elimination, as there's a global drive towards elimination, we would need to find local money in order to fund this, and that was then therefore the need for the investment case.
Okay, and like I have two other questions about some of the parameters, or like the first one is about the cost. Like it is said that the OOP cost, the out-of-pocket cost, is estimated and extrapolated to years later. And I was curious about how this is done and how this is different from maybe other economic cost estimation.
No, not necessarily very different. I think standard sort of economic costing methods were employed in the investment case with respect to discounting and looking at inflation and so on. Yeah, so the out-of-pocket costs were one of the few patient-specific costs that were taken into account in the investment case.
Okay, but I have a follow-up question about that, because I was thinking the medical cost or the OP cost is somehow like more influenced by other factors. For example, you have to consider the policy, the insurance policy, or the social security part. And so like, is this taken into account or just remained like estimating like it is remain the same situation like years later?
So what you need to remember, that this is for from the point of the investment cases from the provider perspective, that it's about the amount of money government needs to spend in order to achieve eliminations. That's the one thing. With respect to insurance and social security, the setting in where malaria is prevalent in South Africa is such that such concepts don't really exist. It's all publicly it's all the public health system. So your out-of-pocket payments are really things that are about the cost of childminding, the cost of missing work for a day to get to a clinic, the cost of transport. It's those low level costs.
Okay, thank
Great.
you.
Maybe we can, I know that we're just a couple minutes before the end of the hour, and I want to be very respectful of your time. Maybe I just want to take one more question from one of our Moy University students, and then I'd also like to let Lindsay ask a question about age structure in your model. So Khalil is asking about what are the key differences between sort of your malaria dynamic model and your COVID dynamic model. He's sort of wondering, do you really use the same approach for modeling all sorts of outbreaks, or what are kind of the key differences between those two dynamic models?
So the key differences, I think data inputs are key differences. That with malaria, we have decades of data and good quality detailed data that you can calibrate to, which allows you to have a more complex model. For COVID, decisions needed to be made very quickly and without much data. And so in order to be more responsible in terms of our modeling, we have simpler models that can also be implemented quickly in order to be able to be adapted quickly and to provide support for decision making in the time frames that are required. So I think those are perhaps the key differences. Both of them are compartmental, generalized compartmental models, but one is considerably more complex than the other because of the data requirements. And malaria, of course, is more complex. We've got the vector human interaction in your model building compared to COVID, which is human to human interaction. But also our COVID models themselves were complex, and they became less complex, and they became complex in different ways over time as the needs arose. So I'd say once again, I think honestly, it's just it's purpose driven. And I can imagine that as COVID approaches an endemic state, that the form of the model will once again change again as we get more and better data too.
Yeah.
I can skip over to the age question just in the interest of time, because I've read it in the
Okay,
chat.
great. We appreciate that.
An email. So for the age structure, in the report that you had read, that was at the end of the first wave. Now, it was not incorporating age in the first COVID models was a decision that I know hasn't really been taken by other modeling groups, but a decision we took because of what was required of us. At the point of the model that you had read about, it was actually implemented in a meta-population framework across 52 districts in the country. So repeated 52 times, where they were connected via mobility matrices, because the decision at that time was about the spatial relationship between places and planning at that fine spatial level. And also we had very little age-related data. That you had age-related data that was, yes, for admissions, and you had that for cases, but the underlying testing, underlying infection, at the time of developing that report, there was no seroprevalence data. And so we, in fact, I think one of the questions were that, it would have, that the projections would have been much higher in that September report compared to what actually occurred. And the answer is actually no, it was pretty much on point because of our interpretation of the data, knowing that we were grouping the ages together. What we subsequently learned a few months later when the first sets of seroprevalence studies came out is that the younger age groups were not unaffected by COVID at all. In fact, there was a very minor difference between the younger age groups and the older age groups in terms of seroprevalence. Maybe a 10 or 20% difference, but not actually considerable as to what one may have expected. And that's to do with the family structure in a developing country such as ours, where we have the elderly and the young living together, because that's how the social security, social support system and the family system works, or is relevant in South Africa. But following that, when we started modeling again with new variants, immediately we moved with new data to an age-structured data, to take age-structured model, to take into account your age structure in terms of susceptibility to infection, in terms of severity to infection, access to care, and now, of course, who's getting vaccinated and who's not.
Mm-hmm.
Yeah, constant
which
adaptation.
goes back to your point about how important context is when you're approaching these models. Thank you so much. This was really fantastic. I really enjoyed hearing about your experiences, and we really appreciate your time. Thanks.
Thanks for having me, and thanks for the wonderful questions.
All right. Take care. I hope to see you again soon.
You too. Bye-bye.
Bye.